What's up guys, it's Andrea and I'm back again with another video. As you guys can tell by the title, this is going to be another day in the life video, but technically not a day in the life because normally when I do day in the lives, I'm like vlogging. But honestly, I feel like when I do those, you guys don't really get the gist. You guys really don't essentially see like what I'm doing. You guys, if I'm mentioning something, you probably have no idea what I'm talking about. Like if I'm talking about a certain piece of equipment that we use on babies. Nonetheless, this video is going to be me just sitting here showing you guys, well, really talking about different things that I do as a NICU nurse and as a delivery transition nurse, and then basically just like adding in pictures and videos so you guys can understand exactly what I do as a nurse. Just a little insight, I do work in a level 2 NICU, as well as being a delivery and transition nurse. So sometimes like when you get those nurses who are in like level 3, level 4, they don't go to deliveries. A lot of them will have like teams that'll go to like that will go to the deliveries for them. But at my hospital, we not only do the NICU babies, we also go to deliveries as well. So when you come into work, you'll find out whether you're on deliveries that day or if you're in the NICU that day, and then you will stay in that position or that role for the entire day. So obviously I wrote everything down because I feel like I don't want to miss anything, and honestly I probably missed something, but I'm gonna try to make this video as quick as possible. And like I said, I'm gonna insert in different photos and videos throughout the video so you guys can kind of see exactly what I'm talking about. And just a little disclaimer here, all the videos and the pictures that I do post throughout this video are specifically from google.com. Nowhere are they about my hospital. None of them will be pictures of my hospital, the nursery, the NICU, the delivery. None of that will be my hospital. It'll be specifically from googlehospital.com. Okay, so first I want to talk about the role as a NICU nurse. Like I said, I'm in a level 2, so our routine or how we do things may be a little bit different compared to if you're, like I said, in a level 3, level 4. So when I first come in, well, like I said, I'm gonna find out if I'm in deliveries or NICU. Well, me and my preceptor, not me yet, but we'll find out which, role we're in for the day. And so if we're in the NICU, we'll come in, we'll get report, and we will get report on each baby we have. Of course, like when you're giving a report, getting a report, you want to make sure you get all the information you need. What schedule are they on? What are they eating? Do they have an NG tube? Do they have an OG tube? Do they, have an IV site? What does it look like? Do they have a UVC? All these different things you want to make sure you know, as well as like, is the mom coming in? Is she breastfeeding? Is she allowed to breastfeed? Like, are there any standing orders? Do I need to do any labs? Did you do any labs? What do those labs look like? So really just making sure, like I said, you're getting all that information that you need. And if you are not given that information, you need to figure out a way how to get that information, whether that's you asking, you looking it up in the chart. You want to make sure you get everything that you need to know before you start your day. And then after that, once I get report and I make sure that I have everything that I need to start my day, I will then set up the bed. So our babies are either on the 8 o'clock schedule, so they'll have their touch times at 8, 11, 2 and 5, or they'll be on the 9 o'clock schedule, which is 9, 12, 3 and 6. So sometimes, depending, because you can get anywhere from 1 to possibly 4 babies if they're like all feeder growers, but 9 times out of 10 you'll probably end up with 3. Sometimes you'll end up with babies, like you'll have 2 babies on the 8 o'clock and 1 baby on the 9 o'clock. So it's really important to essentially plan your day. Like, how are you going to do this? How are you going to make sure that your feedings are not late, your touch times are on time, and each baby is getting the care that they need at the time which it is needed. So planning your day, and like I said, going to set up your beds. So with me, if I know a baby has an OG tube, NG tube, a UVC, I'm going to grab all the supplies for that, syringes, flushes, everything that baby is going to need for the day. I'm going to make sure it has it in its bed, so I don't have to keep going back and forth to the supplies, to the baby's bed, to the supplies. Like, it's just too much. You rather just have it all together at once. So like I said, any supplies that you're going to need, the milk, the diapers, the towels, the blankets, anything that you possibly can think of, alcohol wipes, band-aids, you can supply all of that inside the baby's bed underneath, so that way you don't have to worry about it throughout the day. So I make sure, whether I have 1 baby or 3 babies, that they all have everything they need before I start my day. So depending on my baby's schedule, if I have babies on the 8 o'clock, I normally start around, just because I'm still kind of new and I don't move that fast. Like, I'm getting better, but I don't move that fast. I normally start around like 7:30, 7:45 with my touch time and getting all my care done. But if I don't have a baby like that's on the 8 o'clock schedule, then I really don't have anything to do until, which this is very rare, but I won't have anything to do till like 8:30, 8:45 to start that baby on the 9 o'clock schedule. So at all our touch times, we do a blood pressure for the first and third assessment. You'll have 4 assessments throughout the entire day. But my first assessment and my third assessment will only include, will include the blood pressure as well as all the other things that I need to get done. And then the blood pressure, I'll do a head to toe assessment if they have any IV sites, if they have UVC. I'll also do, and when I say UVC, I'm sorry, I'm talking about an umbilical venous catheter or a umbilical arterial catheter, which is basically just a line within the baby's umbilicus. So I need to make sure that I'm assessing that it has the correct placement, the OG's in the correct place, the NG's in the correct place. If the baby's on oxygen, that their FiO2 is on what it says it's on. Basically assessing everything. That first assessment is really important because you want to make sure that baby is exactly where it needs to be. And then if you're assessing anything, you know, from that head to toe assessment, you want to make sure that you're documenting and you have everything that you assess in the chart. So aside from the assessment, you are going to change the baby's diaper, of course. If they are feeding, like if they're not in PO, then of course they're gonna feed, whether it's Similac. There's tons of Similacs that these babies can be eating if they have EBM, which is express breast milk. And that's really good for those babies who, if they weren't in the NICU, they would be breastfeeding. So a lot of times we'll have their mom like manually pump and then bring in the milk to the NICU, so then that way the baby can still be having the breast milk. So then if the baby has an IV site, you're going to be flushing this IV site, make sure it's still patent, you don't have any clots. Like I said, if it has a UVC, and I'm saying UVC because my last baby had a UVC, so that's like fresh on my mind. You want to make sure that that's taped in place and has not moved, has not been yanked or anything else, because that's something that's like super important to not move, because that is a very, very important line. You want to make sure that that's still looking good. If the baby's linen needs to be changed, you can get that done during either one of those assessment times, but just making sure, like I said, you're getting everything done that needs to be at that specific touch time, because really that's why we have those touch times Q3 hours, because we don't want to keep like messing with these babies, especially if like their feet are growers and we want them to grow and rest. You don't want to keep messing with this baby throughout the day. So make sure you get everything done that you need to every single touch time, which is every 3 hours. Then the last few things that I kind of want to point out, like as far as like the NICU like standpoint, of course, like throughout the day, you're going to be handling situations like as they come, like if you need to wean the baby's oxygen, if the baby has any medications, like AMP and Gen is one of the main, I feel like that I've seen so far, one of the main medications that we give in my NICU, which are antibiotics for the baby, and they are given on the IV pump through the IV site. We also, I've seen like the babies getting caffeine before, morphine before. So again, in my level 2, I feel like a lot of the medications are like routine. So, and of course, like I said, you're going to be handling those medications throughout the day as they are scheduled. Then one of the last things, like one of the main things I feel like I've seen done is like doing sugar checks. So what we do is a hill stick. Oh, and also labs as well. But we do hill sticks on babies. So basically we'll get their little hill and we will puncture it with a lancet, which is basically just like a little needle that'll put a little, very tiny puncture into the baby's skin. So that way we are able to check the baby's blood sugar for whatever reason, if it needs to be done, and making sure that it's getting done in the time, again, that it's supposed to be done. And like I said, if the baby has any labs that need to be done, we are making sure that we're getting those done. A lot of them that I've seen recently, well, like throughout my time so far in orientation, it's a lot of these babies will need, of course, their 24-hour Billy. Like after they're done, they'll need to have that bilirubin level checked, and then our newborn screen, which is basically, again, puncturing, doing a hill stick into the baby's foot and getting that blood to put it on the newborn screen form. So then that way we are able to send off that form, and basically that test is like for genetic testing to see if the baby has any abnormalities, but that also needs to be done within the 24 hours of life. And of course, guys, there's so many other things that really this video could last for forever, that, you know, certain things that pop up that you wouldn't even, that really aren't routine, and it's really dependent on each baby's case. But like CBC, blood culture, urine samples. Like there's so many things that you could be doing in the NICU, but this is pretty like basic, pretty routine, everything that I just said. So that is it for the NICU standpoint. Okay, and then now from like the delivery transitioner standpoint, let me say this, got like, I already know this video is gonna be long, but I'm just trying to make it as informational as possible. Again, so you guys can kind of get a great outlook on, you know, what I do in my life. But anyway, so you come in, you find out that you're on delivery transition. The main thing that you need to make sure you do before you go to any deliveries is making sure that your beds are set up, the OR is set up, your intubation supplies is set up. And I will try to insert some type of picture showing or video showing basically what these intubation supplies are. What I do when I come in is I'll check our NeoPuff, making sure that all of our equipment that needs to be inside the NeoPuff is there. It's ready to go just in case a baby needs to be intubated. Everything needs to be there in an emergency situation. You do not want to be looking for supplies that should have been in that cart. So when I say set up beds, you want to make sure you go into every single delivery room, whether there's a patient in there or not. You want to make sure that warmer is on. There's blankets, there's a diaper, there's a measuring tape, and there's a hat. So you want to make sure, again, regardless if there is a mother in there or not laboring, you want to make sure that everything is there. You want to check your suction pressure, make sure your DeLee is in there, your catheter is in there, and that your pressure is set anywhere between 80 to 100. So, of course, we have laboring moms in delivery rooms, but you also want to make sure that your OR is set up, especially, again, even if you may not have a C-section on the schedule, you never know what could happen. I've already been in emergency situations where we had to run to the OR and, you know, we had to make sure that everything is set up because you never know what's going to happen. So basically, same thing with the OR. You want to make sure you have your hat in there, especially because it's super cold in the OR. You want to have your measuring tape. You want everything I just said. Same thing you have for the delivery room. You want to make sure you have that in the OR. You may even want to have extra blankets. You want to make sure also that you have your sterile gown ready, still in the package. So when it is time to go to that delivery, you're able to open the package up, hurry, put your sterile gown on, put your sterile gloves on, and you're ready to go. Again, making sure you're checking your suction pressures, your NeoPuff is connected to the oxygen set. We do at 10 liters, which is the recommendation for neonatal resuscitation, having your oxygen set at 10 liters, connected to your NeoPuff. Check your PIP, check your PEEP. Again, I'll try to put pictures and videos in here so you guys can kind of see what I'm talking about. You need to make sure you're checking everything is set and everything is ready to go. So once you make sure that everything is set up in the laboring rooms and also in the OR, you basically just wait until you get that call that, you know, a labor is happening, a baby is coming, like we need you in the room. So if you're, of course, going to a laboring room, you're going to go to that room. You're going to make sure that your warmer is, again, turned up. Your blankets are warm. You do not have to be sterile, but you can put a gown on because you don't want vernix and blood all, you know, you don't want that. Make sure you have your gloves on and you're ready to catch that baby. So when the baby comes out, the doctor will pull the baby out. We'll set the baby on mom's chest and you will be right there. You'll have that blanket and the baby will let me say this. The doctor is not setting the baby on the mom's chest. Actually, it'll be on the lower abdomen and you will be there with the blankets, holding the baby, making sure the baby is staying warm because that is one of the main concerns when that baby is fresh out. You want to make sure it's maintaining a warm temperature. We do not want our babies to get cold. So making sure you're wrapping that baby, even though it is still connected to the cord has not been clamped, making sure that it is covered as much as possible. You're drying, you're stimulating, doing all the recommendations that NRP says to do, drying, stimulating, suctioning, really stimulating, especially if like the baby is not looking 100% great. You want to make sure that you're doing all those initial steps to make sure that your baby is looking good. The minute passes, the doctor will then clamp the baby's cord. Depending on how the baby's looking, if you think you need to take the baby to the warmer to do, more things, if you think the baby needs some CPAP, needs some blow-by oxygen, you will then take the baby over to the warmer. But let's make this situation a good one. Let's say baby's looking good. At that point, you will then, make sure mom's gown is unbuttoned. You will flip the baby over, do skin to skin, but also listen to the heart. You want to listen to the lungs. You want to make sure baby's sounding good, looking pink. Add the diaper. We put bands on. We put a sensor on. Put the baby's hat on. You want a temperature. You want all these initial assessments done. So then that way, when you return back in 15 minutes, you want to make sure you have something to compare to. You want to make sure you have those baseline vital signs. So baby's looking good. You want to make sure that I probably go about every 25 to 30 minutes. maybe in the beginning, like if I'm questioning, maybe this baby doesn't look 100% great, but there's, maybe I talked to the doctor said, hey, just keep an eye on baby. You may want to make that, assessment time more often, maybe go in there every 15 minutes, listen to the heart, listen to the lungs, get a temperature. You're going to continue to do that basically until the baby goes over into postpartum. But for the most part, you want to make sure you promote that skin to skin time. Tell mom, hey, we want to make sure baby stays on you, skin to skin, for that full hour. And then after that, we can either wrap baby up. You can still hold baby for an hour if you want to, depending, on what mom wants to do. But for the most part, you want to make sure that baby stays on mom for that full hour for skin to skin time. So, main thing for that first hour of life is making sure that baby does that skin to skin. But then also you want to keep in the back of your mind, especially if you have heck of deliveries going on, you want to make sure that these babies get their eyes and thighs within the first 2 hours of life. So you're going to make sure that baby gets vitamin K and baby gets the antibiotic ointment, as long as the parents are okay with it, which for the most part they should be. You'll get some questioning with the Hep B, but we'll talk about that in a minute. But do please make sure, again, if you are about to be a new grad or whatever in this position, you gotta make sure that your baby is getting these eyes and thighs. It's recommended within the first 2 hours of life. So normally what I do is once they're done with their skin to skin time, I'll then take baby over to the warmer. I'll get all the measurements, the weight, the head circumference, everything that needs to be done as far as measurements. Also, like the head to toe assessment, I'll do that after my the hour of skin to skin time, and then bring baby over to the warmer. Like I said, get all that done, put it on the scale, bring it back, do a head to toe assessment, and then I will do the eyes and thighs. And then at that point, if I have the Hep B available, I'll also give the Hep B, as long as the parents gave consent. Also, something I didn't mention earlier, so that's kind of what I like to do, a part of the process of like setting up, like when I'm setting up the OR in the laboring rooms. If the parents have not signed the consents yet, I want to make sure that I go into the room, talk to them all about the Hep B, answer their questions for the Hep B. Totally up to them if they want to get the Hep B or not. They're gonna sign the consent either way, like, hey, I'm consenting for you guys to do this, or hey, do not. Again, but that's totally up to them. But going back after the delivery, like I said, once I realize that, hey, they signed the consents, I want to try to get all that done at one time, because I don't want to keep unwrapping the baby, poking, wrapping it back up, then unwrap the baby like 20 minutes later when I have the Hep B. But I want to make sure that, like I said, I'm getting it done. All this care that needs to be done, I'm kind of clustering it together so I'm not continuously messing with this baby. Another thing, I'm like looking at my notes. I haven't been like for the past 5 minutes, but another thing also that I want to point out is, so once that cord is clamped at 1 minute, you want to get an ABGAR. And I will try to put a chart in here so you guys can kind of see what the ABGAR, how you get your ABGAR scoring, because you want to get one at 1 minute and 5 minutes. And a lot of times that ABGAR at 1 minute will tell you whether or not that baby can stay with mom, or that baby needs to, go over to the warmer for more care. But you want to make sure you're getting those ABGARs, because once it's all said and done, one, you need to document it, and two, the doctor is going to ask you, hey, what are the ABGARs? So it's really important to know how you're getting the scoring. Like I said, hopefully you guys can pause the video on that chart so you guys can see how you come up with the ABGAR score. And so basically it's the same thing if you were in the OR. The only difference is, one, you need to be very cognizant to the temperature in the OR, especially if you have like a preemie coming out and the baby you already know is gonna have a hard time maintaining their temperature. You wanna move with urgency. Like I said earlier, you wanna make sure when you're going into the OR, right before mom is about to be cut open, that you have your sterile gown on, you put on your sterile gloves, and you remain sterile until the doctor hands you baby and you turn away from mom. Basically, the main thing there is not really for baby, but more so protecting mom and making sure that we're not exposing her to any infection. And then anyone who's coming into that area, or near her open, cut there, her open wound, not even a wound, but like her being open, you want to make sure that you are not introducing any bacteria into her body, because that would be very, very dangerous. So making sure you're staying sterile. So same thing once you bring baby over to the warmer in the OR. At that point, this is a difference here. So since the scale in the OR has, or the warmer in the OR has a scale, I will, do the baby's weight there. And it's different because at that point, mom can't hold baby. So you might as well get everything done that you can. So I'll then take the weight, I'll get the FOC, I'll get the length, like everything that I would wait an hour for. Like if we were in the laboring room, I would just go ahead and do it in the OR. which is really to a benefit because you can get more stuff done. So once I'm done with that, I will wrap baby up, and then I will walk it over to mom, show mom, let them take a picture. If she has dad in there, if she has like grandmother or whoever in there, let them all take pictures. And then at that point, either the baby will go back to the room with dad, or it'll go into the nursery with us until mom is out of her section. Then at that point, you're really, like I said earlier, gonna just be assessing the baby every 30 minutes. And then once the hours go on, you can do every 45. But at that point, baby and mom should really be transferred over to postpartum. And so they're off your hands, they're out of your care. And you really essentially just get ready for the next delivery, or you're still, working or assessing on another baby that was delivered earlier. But I really feel like I forgot something on both of these, roles. But essentially, that is like the most basic, probably rundown that I could give you guys, and kind of show you guys these pictures again, so you can kind of, get a good look of it. But for the most part, for a delivery transition, that is exactly what it looks like. But just be very cognizant that you could have all this going on at one time. Like, you could have a delivery at 1:05, and then 1:30 you're getting another call that, hey, we're about to have another delivery. But at the same time, you need to make sure that you're still keeping up with that first delivery, and you're still assessing that first baby. So a lot of times with us, like if we see on the board that we have a lot of deliveries, we'll have more than one transitioner, so that way it's very feasible, it's very able, you're not like running around with your head cut off like a chicken. So for the most part, it's very doable, just making sure. And again, with me being on orientation, like I'm still having to master time management and being able to understand that I still have to keep up with all my patients, regardless of how crazy or overwhelmed I may seem. I still have to make sure that I'm getting things done. But that's pretty much it for this video, you guys. Hopefully, I'm like crossing my fingers here, because I want to make sure you guys get a better outlook on what it looks like, and not just me vlogging and really getting like, I just feel like you guys don't get the whole gist of it because you don't really get to see much. But hopefully by me doing this video, you guys kind of got a better outlook on what it looks like for me as a nurse. So I hope you guys enjoyed it. Give it a thumbs up if you did, and I'll see you guys in the next video.